but we are going to get started as we get this thing set up because we have about, a limited amount of time. But really delighted to welcome you to this year's this semester's iChat speaker series. And maybe I should start by introducing myself. My name is Neil Tutlam. I'm an assistant professor at the Brown School here and associate director for research at iChat. So the iChat speaker series provides a platform for faculty and other experts to discuss their research on current global and societal, economic, and health issues. Our goal is to bring together experts, researchers whose presentation foster the learning and inspiration for future generations, such as yourselves, those of you seated here, of researchers and practitioners whose work really contributes to the reduction of poverty and improvement of developmental and public health outcomes for children, adolescents, and their families in particularly low resource settings. We work in Uganda and most of sub-Saharan African countries. And for those of you, and then for also your information, our next speaker series is going to be October 15 in this very room, where we will hear from Dr. Oliver Ezichi, who will talk about the brain gain with global public health, a tale of capacity building strategies from Nigeria to the US with policy implications. So mark that on your calendar. October 15th is going to be our next speaker series. And now it's really my great honor to introduce our distinguished scholar, visiting scholar today, Professor Pauline Byakika, who has conducted extensive research on pharmacokinetics and drug interactions of antimicrobial and anti-malaria and anti-tuberculosis drugs in African populations. Her work significantly advanced the understanding of how antiretroviral therapy used to treat HIV affects malaria treatment when co-administered to individuals living with HIV in sub-Saharan Africa. The research has contributed to global insights on managing co-infections, particularly in resource-limited settings. As a result of her contribution, she has been recognized as a fellow of the Uganda National Academy of Sciences and Royal Colleges of Physicians of Edinburgh. In addition to her research, she has played a pivotal role in HIV clinical trials and capacity building projects, serving as principal investigator or co-investigator on a number of HIV and NIH-funded studies. She's one of our collaborators. She's also deeply committed to research ethics, and we've collaborated with her in that sphere as well. Serving as the director of Research Directorate at Makerere University previously, and a key member of the Uganda National Accreditation Committee for Research Ethics Committees, which is really important work. As you all know, for us to be engaged in research, we have to also emphasize that component of ethics work. And her efforts aim to reduce morbidity and mortality from infectious diseases through research, clinical care, and the training of the next generation of health professionals. So that's a big CV, but it gets even better. So Professor Pauline recently got appointed as the Vice Chancellor for Makerere University, and I should note she's the first female Vice Chancellor of that institution. And so this is really it's a big deal. Those of us who work with her are very excited for her to take this role. We're always looking to partner with great institutions on the continent, and we believe that she will be that partner and champion that partnership. Without further ado, Professor Pauline, you're most welcome.
Thank you very much, Tutlam, for that very kind introduction. Good afternoon, everyone. I'm so pleased to stand here this afternoon to deliver this talk. And I want to start by thanking Dr. Fred Sewamala, Bethel, Chesi, Tutlam, for inviting me to present to you this afternoon. Thank you very much. So I'm going to talk about the global threats and drivers of antimicrobial resistance, with special focus on sepsis and malaria. I have been introduced, so I'll not repeat that. But I want to start by saying that I think many of you in the room have not seen a patient with malaria. Have you? If you have seen a patient with malaria, please put up your hand. Okay, all right. And if you have seen the malaria parasite, please put up your hand. If you have seen the malaria parasite, please put up your hand. Straight up. Oh, there are very few hands in the room. I think there are only 3 hands up. So the malaria parasite is very, very small, can only be seen under the microscope, but it causes a lot of morbidity and mortality. And that's why I'm here to talk to you today. This is the outline of my presentation. Unfortunately, the slides cannot be displayed. We'll have to do without them. I had prepared some beautiful slides for you. And those of you who haven't seen the parasite before, you will miss the opportunity to see it on my slides. So my outline, I'll tell you a brief history about malaria, and then I'll go into the epidemiology, a little bit on immunology and pathophysiology of malaria, the clinical presentation. I'll talk about sepsis and malaria. We'll talk a little bit on malaria treatment, prevention, and finally on antimalarial drug resistance. So the history of malaria. Malaria dates back as far back as 400 BC, when it was characterized by poor health with fever and enlarged spleens amongst people who lived especially in the swampy areas. So at that time, it was called mal air, and that's where the word malaria came from, the name of the disease, mal air, because in the swampy areas, there was bad air, and people fell ill with fever, and they had big spleens, so the disease was called mal air. So a French scientist called Charles Alphonse Leveran discovered the parasite in 1880. Unfortunately, you can't see the slide to see the parasite. But in 1880, he discovered this parasite, and he received the Nobel Prize for that discovery. Then another scientist, this time an Italian scientist. I need to get this bar, the toolbar off the screen, so that I can see. Can I get it down? Okay, yeah. Good, thank you. So another scientist, Ross, discovered, together with a group of Italian scientists, maybe 6 or more Italian scientists, discovered the vector that transmitted malaria, and that is the mosquito in the 1890. And in 1902, Ross, who discovered the malaria vector, which is the Anopheles mosquito, also received the Nobel Prize for this discovery. So malaria is caused by the Plasmodium. Plasmodium, it has 4 species, but it's transmitted by the mosquito, through the mosquito bite. The slides are me. I don't know, the technology this afternoon is
working again with us.
Yeah. Okay, it's now working. Good. So there are currently 5 species that cause malaria in humans. There are many other species, but most of the others cause disease in the animals, including the cattle. For humans, we have 5 species that cause malaria. We have Plasmodium falciparum, Plasmodium vivax, Plasmodium malerei, Plasmodium ovale, and Plasmodium knowlesi. The other 3, vivax, malaria, and ovale, cause uncomplicated malaria, but they also cause recurrent malaria. Plasmodium falciparum causes the most severe cause of disease, and we shall see why. Knowlesi also causes severe disease, but it's less common. It's more in Southeast Asia. So on a global scale, falciparum causes the most severe disease and the highest number of malaria cases. Malaria is distributed mostly in sub-Saharan Africa. We don't see much malaria elsewhere, but mostly sub-Saharan Africa, mainly because of the climate there. I had some good maps to show you, but unfortunately you cannot see them. Okay, yeah, if you log online, you'll be able to see the maps. Okay, so globally, and according to the last malaria report, which is the 2022 report, there were 249 million cases globally. And out of these 249 million cases, 93%, close to 94%, occurred in the African region. 94% of the cases. And of the number of deaths globally, 95% occurred in the African region. So malaria is mostly concentrated in the African region. Globally, it's concentrated in about 85 malaria endemic countries. I will now zero down to Uganda. In Uganda, where I live, we have stable malaria transmission. And in a year, in 2022, we had roughly 20 million cases in the whole country. And when we look at the statistics in our hospitals and outpatient clinics, we see that malaria causes the biggest burden of disease, contributing 30 to 50% of outpatient visits, about 15 to 20% of hospital admissions, and about 20% of all deaths in our facilities. So malaria is a big problem in Uganda. Malaria control largely depends on treatment of cases of malaria, together with the other interventions. For example, indoor residual spraying in the homes, as well as use of insecticide-treated mosquito nets around the beds. But largely, use of treatment, effective anti-malarial drugs to treat the cases, because when you treat, then you stop transmission. In terms of risk, who is at highest risk for getting malaria? It's mostly the children younger than 5 years of age and people with reduced immunity. For example, those infected with HIV, because we know HIV causes immune suppression, and that immune suppression causes risk for malaria. The other category of patients, of individuals at risk for malaria, includes the pregnant women, especially the prime gravidas, because we know pregnancy has an effect on the immunity, and therefore this puts them at risk for malaria. Then patients with sickle cell disease are also at high risk for malaria, as well as non-immune travelers. Those who have been living where there's no malaria do not have any immunity at all to malaria. So when they come to malaria endemic areas, they're at very, very high risk. Unlike those of us who have lived in malaria endemic countries where we are bitten by infected mosquitoes and our bodies develop antibodies that provide us with passive immunity, so that when you're bitten again and the mosquito injects sporozoites of malaria in your system, your immunity is able to suppress the parasites such that you don't come down with disease. So we grow up with some form of passive immunity against malaria. And this naturally acquired immunity protects us from clinical disease as well as severe malaria. But at the same time, that population between about the age of 7 years until about 15 years forms a reservoir of parasites because they have this immunity, they're not falling sick, and therefore many of them will walk around with parasites. And if mosquitoes bite them, then they can transmit to another person. And if they transmit to a person with lowered immunity, then that person is likely to come down with disease. So the life cycle of the parasite, I hope you can see it on your screens. It starts with the mosquito that is infected with malaria sporozoites in biting an individual and injecting these sporozoites under the skin. Within a few minutes, these sporozoites will migrate from under the skin through the circulation into the liver to start up what we call the hepatic stage of the parasite. They will develop within the parasite, and the cells will then rupture, release merozoites, and these merozoites will go out into circulation to infect red blood cells And the red blood cells also, the parasite goes through a series of events and a life cycle in the red blood cell that causes the red blood cells to rupture, release merozoites that go on to infect more and more red blood cells. But also these merozoites will go on to develop into the gametocytes, which are the reproductive cycle of the parasite. And these can be transmitted when the mosquito bites that individual to transmit to another person. Now, the same merozoites, when the red blood cells rupture, will then set up the cascade of disease. Because with this rupture, we have, a release of merozoites, release of cytokines. And as you all know from immunology background, these cytokines then will set up the consequence of disease, setting up symptoms like fever, headache, joint pains, anemia because of the rupture of red blood cells. So the disease symptoms that we see are a manifestation of this rupture of red blood cells and release of these chemicals, the cytokines, manifesting as disease. Okay. All right. So in terms of immunity to malaria, we have both the adaptive and the innate immunity. The adaptive is what I described. For those of you who live in malaria endemic areas, develop memory immunity with release of antibodies that protect you from subsequent episodes of malaria. And the innate is what I have just described that involves a whole series of these cytokines and all that kind of thing. So in terms of pathophysiology, how does somebody actually get sick with malaria? As I said, these malaria parasites will develop from sporozoites, go into the liver, they get into the red blood cells and develop what we call merozoites. And once these malaria parasites are within the red blood cell, they cause structural changes to the red blood cell. And the red blood cells then become sticky and develop sticky knobs on the surfaces such that they stick together. Because they are sticky, they stick together. The red blood cells will stick together. The white blood cells in circulation will also stick to these parasitized red blood cells, and so on and so forth. So the pathophysiology of malaria is characterized by occlusion, sequestration, and agglutination, rosetting, sequestration, occlusion, and agglutination. And these cause blockage of the microvasculature because they are sequestering into the peripheries. They are causing rosettes. Rosettes are like balls because everything is clamping together because of the sticky knobs. Then they cause reduced blood circulation to the peripheries with ischemia. And that's how I relate it to the sepsis that we're going to talk about and the antimicrobial resistance later on. So the pathophysiology is marked by those four that I have talked about. And this is facilitated by some adhesion molecules. We have the vascular adhesion molecules, the intercellular adhesion molecules, and other molecules like the chondroitin sulfate beta, which is in the placenta, the CD36 in some parts of the body, including the brain, and the vascular, the VICAM1 that is on the endothelial surfaces. So these are all attachment receptors that enable the parasitized red blood cells to get attached to endothelial lining of the red blood cell, and more attachment will occur, causing blockage of blood circulation. Okay. There's an echo. Sorry? There's an echo. Okay, it's now off. Okay, so regarding the manifestations of severe disease, we see that this occlusion, the sequestration, the agglutination will result into a lot of pathology into the organs, in the organs of the body. And that is how malaria causes severe malaria with multi-organ failure. So in the brain, we shall see cerebral malaria. Why do we see cerebral malaria? Because the parasitized red blood cells get occluded, they form rosettes within the small vasculature in the brain. But at the same time, the cytokines that I talked about that are released cause increased permeability of the vessels, causing leakage of fluid. And therefore, this leakage causes edema in the brain, causing cerebral malaria. with hypoxia and all that causing reduced levels of concentration. So that is characteristic of cerebral malaria. The patients will eventually go down from having confusion, convulsions, eventually declining into a coma, and if not treated, they will die. So cerebral malaria is characterized by that. Then the other features of severe malaria include hypoglycemia, because these patients cannot eat. At the same time, the liver is also affected by malaria, and therefore gluconeogenesis is impaired. Then we see acidosis. Acidosis is also coming from the fact that the peripheral vasculature is blocked off, oxygen circulation is impaired, and therefore we get anaerobic respiration with lactic acid production, causing a lot of acidosis. The other features include pulmonary edema, which is also coming from the increased permeability of the blood vessels, causing leakage of fluid, and therefore causing pulmonary edema. Then we have several other abnormalities, including hematologic abnormalities, anemia because of the bone marrow suppression. At the same time, we have the red blood cells are rupturing, causing, hemolysis is taking place on a very big scale, and therefore we get patients with severe anemia. Renal impairment also occurs, still because of renal failure, because of hypovolemia, but also at the same time, we see that the impact of the red blood cells within the tubules and the impact of hemoglobinuria, because of massive hemolysis also affects the tubules, causing renal failure. We also have shock, respiratory distress, and so on and so forth. The features of severe malaria are very many. Because of time, I'll not go into detail of each of them. So the presentation, you can describe the presentation of malaria from the head to toe, right from having a fever, joint pains, chills and rigors, to cerebral malaria, coma, hypoglycemia, seizures, cranial nerve pulses, pulmonary edema, shock, cardiac failure, dysarrhythmias, acute renal failure, severe hemolysis, jaundice, and so on and so forth. They're quite many. Okay, now I'll talk about malaria and bacterial infection, and this is partly the focus of this lecture. So as I said, when somebody has parasitized malaria, red blood cells in the system, we get sequestration and blockage of the small vasculature. This causes ischemia. Now with this ischemia, if it's occurring in the GIT, we get a lot of necrosis. And this necrosis and ischemia in the GIT will eventually lead to, what does it lead to? Sorry, if you have ischemia, you have necrosis, you're going to get secondary bacterial infection. And if it's in the GIT, you're mostly going to get gram-negative septicemia. So patients with malaria also often present with sepsis. And when we are caring for patients with malaria, it's always important to do a CBC to check if they have evidence of a bacterial infection. And if they are presenting with altered levels of consciousness and other neurological manifestations, it's important that you also evaluate their CSF to ensure that they don't have septic meningitis. Okay, so in summary, for this slide, I'm saying that patients who get severe malaria are predisposed to getting bacterial infection and septicemia because of the pathophysiology of malaria. And they often require antibiotic therapy, starting off with broad spectrum antibiotics. And later on, once you have got the culture and sensitivity to determine the specific bacteria causing sepsis, then you narrow down to the specific antibiotic for that to match the culture and sensitivity. In terms of research, the incidence of septicemia has been shown to be about 1.1% in prospective series of patients with severe malaria. And hyperparasitemia was seen as a risk factor for this bacteremia. 6% of children hospitalized with severe falciparum malaria in Africa are also bacteremic. So there's a very big intersection of bacteremia and malaria, and these two have to be considered together. And both antimalarials and antibiotics will often be prescribed together because of these concurrent infections. Okay, so I said mostly it's going to be gram-negative septicemia, and mostly it is seen mostly amongst the children, and therefore when we are dealing with children with severe malaria, it's important that we think through this septicemia and give them the necessary treatment. And this septicemia may also present with systemic manifestations, for example, with pneumonia, meningitis, or urinary tract infection. So it's important that we keep this at the back of our minds. So in terms of diagnosis, how do we diagnose malaria? We know that malaria can be diagnosed by looking for the malaria parasites in the blood from a blood smear and looking under the microscope. But we can also diagnose malaria from the antigens on a rapid diagnostic test, looking at presence of the antigen with the antigen rapid diagnostic tests for malaria. This is what we use mostly, especially in resource-limited settings, because the microscopy will require power, will require trained personnel, will require presence of a good microscope, because if the microscope is poor quality and the staining is poor quality, you're going to diagnose artifacts as malaria. So without a good setting and without good resources, the RDT comes in handy. The RDT, that is a rapid diagnostic test for malaria, comes in very, very handy. However, we are seeing from research that also the RDT now has challenges, because research has shown that there are some mutations in the parasites that cause deletion of some of these antigens that are detected in the rapid diagnostic test. So in the end, you may end up having a false negative test simply because the parasite has mutated, and therefore you might miss the diagnosis. So diagnosis of malaria is very, very important. But we have to know that there are challenges, and those challenges have to be looked into, because if you don't, then your patient is going to die, because malaria kills, and it kills within hours. Okay, so in terms of management, how do we manage malaria? If it's uncomplicated malaria, we manage malaria orally with orally administered drugs with combination therapy. We use artemisinin-based combination therapy. In Uganda, our first line is a combination of artemether and lumefantrine. We have the alternative as artemether in a combination with amodiaquine. But there are other alternatives. There's dihydroartemisinin piperacin, which we use as our second line therapy for malaria. When patients have severe malaria, it's very, very important to make a prompt diagnosis and deliver the drugs as fast as possible with the fastest route that is going to get these drugs into circulation. And that is the intravenous route. And research has shown us that intravenous artesunate works far, far better and faster than intravenous quinine. So our first line treatment for severe malaria now is intravenous artesunate. However, intravenous artesunate is a very short-acting drug. The half-life is very, very short, just about 3 hours. At the same time, it acts very, very fast to clear parasites, but it will not clear all the parasites. And you cannot give it forever because it has a very short half-life. Therefore, it is important that you combine it with a longer-acting drug. So we initially start off the treatment with this parenteral artesunate, but once the patient is able to take oral treatment, and after a minimum of 24 hours of IV administration, then we switch to the oral combination therapy with artemisinin-based combination therapy to complete treatment and be able to achieve cure and prevent recrudescence of parasites. Now, there are some other modalities of treatment that are under research, and these include monoclonal antibodies. So in Uganda, we are not currently using monoclonal antibodies, just like many other African countries, but there's a lot of research on these monoclonal antibodies, and there's hope for the future that these will be available. These monoclonal antibodies can act at 3 primary points in the life cycle. We have those that act at the pre-erythrocytic cycle before the parasites goes into the red blood cells. We have those that act pre-hepatic cycle before the parasites infect the hepatocytes in the liver. And we also have those that work on the sexual erythrocytic stage. There is a lot of research ongoing. As I said, this is not yet standard of care, but we are very, very hopeful that these monoclonal antibodies will transform management of malaria. In terms of prevention, as I said at the beginning, We mostly prevent malaria through use of insecticide treated mosquito nets to prevent bites of the mosquitoes. But we also use the indoor residue spraying on the walls within the houses so that the mosquitoes, once they fall on the walls, they will be killed by the insecticide. So we know that the mosquitoes that carry malaria mostly rest inside the houses, and they also mostly bite from inside the house. Those that bite from outside and bite earlier in the day usually do not carry malaria parasites. Those that carry malaria parasites will be found inside the house, they bite later in the evening, and they bite from inside the house. And therefore, the targeted intervention is to spray the insecticides on the walls. However, like any other living organism, these parasites and these vectors are very, very clever. So they mutate. So now we are seeing, because we've been spraying a lot of walls in the homes, the vectors have also learned to rest outdoors, bite from outside, to dodge the insecticide. So it's a big problem. And we have to keep thinking and doing research to try and find new insecticides that can kill mosquitoes both inside and outside the houses. The other form of prevention that we use is chemoprophylaxis. Chemoprophylaxis is administration of drugs to prevent one from falling sick. So we are doing this in some areas of very high malaria transmission, where we do what we call seasonal malaria transmission. So every season where we suspect that where there's documented high transmission of malaria, we go out and give the population that is at highest risk, that is the children, drugs in terms of chemoprophylaxis to prevent them from getting malaria. But we also give these drugs to pregnant mothers, to children with sickle cell disease, to HIV-infected individuals, to take regularly so that we prevent them from getting malaria. The other form of prevention that is now bringing a lot of hope to us who are living in Africa is the malaria vaccine. At the moment, we know that there are 2 vaccines that have been approved for use. That is the RTSS and the R21 malaria vaccines. We haven't yet received them in Uganda, but our neighboring countries have already had some of these vaccines. For example, Kenya has already received these vaccines. The RTS vaccine targets the circumsporozoite protein of the sporozoite that I talked about, and it was the first vaccine recommended by WHO in 2021. And it's given as a 4-dose regimen, and it is very, very promising. The second vaccine is the R21 vaccine, and this one also has shown very high efficacy when given just before the high malaria transmission season, resulting in 75% reduction in symptomatic cases during the 12 months following a 3-dose vaccine. And the 4th dose given a year after the 3rd also maintained this efficacy. So there is hope that these vaccines will eventually bring down the burden of malaria, especially in Africa. However, we cannot rely on them as a single intervention. We still have to continue using them in combination with all the other interventions, the mosquito nets, the indoor residue spraying, the chemoprophylaxis for maximum benefit. Yes, so when I started this talk, I mentioned the high-risk groups, and I said that those people who have been living in areas where there's no malaria, once they return or come to visit in areas where there's malaria, they are at very high risk for malaria because they don't have that passive immunity. Even the Ugandans, if I came to live here and stayed here for maybe 2, 3 years or 5 years, when I return to Uganda, I am at higher risk for malaria than my counterparts who have stayed in Uganda constantly. And hence the importance of this slide. This slide is talking about prophylaxis for non-immune individuals. So we have a Uganda malaria treatment guidelines that are formulated depending on the efficacy and effectiveness of the drugs in the country. So for Uganda, if individuals are coming to visit in Uganda where we have a lot of malaria, there are some drugs that we will not recommend you to take because the resistance profile is very, very high. For example, we will not recommend you to take Fancida, which is sulfadoxine pyrimethamine. We shall not recommend you to take some of the other drugs, which maybe I don't have to go into. But we have a list of those that we shall recommend that have been documented to work, both as prophylaxis and as treatment. So for prophylaxis, We recommend tovacone, progranil combination. It comes as Malaron and it's taken daily. We don't recommend chloroquine that you see up on the slide. We also recommend doxycycline that is also taken as a daily tablet. And the other one is mefloquine. So from the slide that I have shown, doxycycline, Malaron, and mefloquine can be taken by travelers who are coming to Uganda because we have documented that the resistance profile is not at levels where it will prevent you from using it as prophylaxis for malaria. Now I'll move to the resistance topic, the anti-malaria drug resistance. Anti-malaria drug resistance is a global threat. Why is it a global threat? Because we don't have many antimalarials to use. Currently, the approved artemisinin-based combination therapies are only 6 by WHO, approved by WHO, only 6. In the pipeline, probably we have only maybe 2 very close in clinical trials to probably getting anywhere near being approval. And as we all know, the process of drug development takes several years, over 15 years. And therefore, it is important that we protect the drugs that we have currently. This anti-malaria resistance was first observed in Southeast Asia, in Western Cambodia. And at that time, everybody talked about it. It was a big threat, but probably people thought it wouldn't spread to other parts of the world or malaria endemic areas, or probably this resistance wouldn't develop in other areas. But as we speak, resistance has been documented in other areas, including Cambodia, Vietnam, Myanmar, Thailand, and including East African countries, Uganda, Rwanda, and some other countries like Eritrea. This resistance, some of it spread from one area to the other, from the human population movements. However, we also note that there's de novo development, emergence of resistance in areas where it was not suspected before, meaning it's not necessarily spread from one area to the other, but the parasites in one area then mutate and develop this drug resistance. So this is really, really concerning. And it is the work that we are focusing on and I'm focusing on currently. This resistance arises de novo over time from parasite changes, mutations in the parasites. And currently we have Plasmodium falciparum gene mutations in the K13 gene of the Plasmodium falciparum that have been associated with resistance. They confer resistance through several mechanisms, through drug transporter mechanisms and several other mechanisms depending on the drug and the mechanism of action of that particular drug. So we have over 260 of these parasite mutations documented. However, not all of them are associated with resistance. Currently, I think about 15 are associated. 15 of them confer resistance, with the commonest and the most widely spread being this 580Y mutation. However, there are others. WHO regularly publishes this list of mutations and updates this list because today you might find that there's a mutation that is not conferring resistance, but after several months down the road or several years down the road, you find that it's actually conferring, if documented to confer resistance. So WHO regularly updates this list. And these resistance mutations are the markers that we follow in research to document the prevalence of resistance and to document the effectiveness of anti-malaria drugs. So this slide shows you the mutations that I have talked about, the WHO published list of mutations. And here, this map is showing you the areas where this resistance has been documented. How does this resistance manifest? It manifests as delayed parasite clearance. So when we conduct trials on malaria, therapeutic efficacy trials for malaria, anti-malaria drugs, we administer drugs by directly observed therapy, and we take off blood samples serially over time, 2-hourly intervals. And at those 2-hourly intervals, we measure the parasite counts until parasite clearance. So we measure the parasite clearance time. And this duration of parasite clearance time is an indicator of the effectiveness of the drugs. So the first indication of malaria drug failure would be in terms of a prolonged parasite clearance time. And that is what was first documented in Southeast Asia. And then that went on to the molecular markers that actually documented the mutations that are conferring resistance. And this map shows you the distribution of this delayed parasite clearance time. This map is showing the distribution of these molecular markers. And as you can see, they're concentrated in particular areas with over 80% in Southeast Asia, as you can see on the map, where the dark blue circles are, and less than 10% in areas like East Africa, but they have still been documented in those areas. Okay, so what has happened since this event of documentation of emergence of artemisinin resistance? So as I said, this was documented early on in the early 2000s. And since then, work has been ongoing through WHO offices and country offices, malaria control programs. Work has been ongoing. In Uganda, we have documented and mapped out the prevalence and the hotspots where anti-malaria drug resistance exists. And we're now currently working on a strategy to combat this anti-malaria resistance. We've mapped out the drivers of resistance, and we're now doing molecular studies, anti-malaria effectiveness studies, as well as field studies to try and follow the series of events. Sorry, my slides have hung again. This technology, I don't know what has happened. They're hanging. Okay, so this slide is to tell you about the potential drivers of anti-malaria resistance that we have documented from literature and studies in Uganda. And these include things like the environmental changes, the climate change. With climate change, we get a lot of alteration of temperature, humidity, and the parasites are able to survive better. And some of them are able to become even more fit for the particular climate. And the vectors are also surviving better, and some are also getting more fit in terms of transmissibility of malaria, of the malaria parasite. So we have also documented some vector factors, like I told you, evasion of the insecticide resistance, the insecticides that we are using for prevention of malaria. And with this evasion of insecticides, they are able to transmit more resistant parasites because they're evading the control measures. Then the host factors, in terms of human migration from one place to the other, in terms of reduced immunity for some of the humans, and so on and so forth. And that facilitates transmission of these resistant parasites. But at the bottom line are the parasite factors, because it is the parasite that mutates. And this is from this initial mutation that we get transmission and continuous replication into more resistant parasites. Then, of course, we have the problem with the drugs, standardization of the drugs, counterfeit drugs, subtherapeutic concentrations when patients take the drugs, and so on and so forth, poor adherence to the drug regimens, and so on and so forth. And this is a big problem. Actually, the drug factors are one of the biggest problems that we are seeing as a big driver of anti-malaria resistance in the region. Okay, so some researchers have modeled this anti-malaria resistance, and the data from modeling shows that if nothing is done about this resistance, we're going to have an upsurge of malaria cases globally, but of course, mostly in the malaria endemic areas, okay? Widespread artemisinin partial resistance with 54% of infected individuals experiencing delayed parasite clearance could result in an additional 16 million cases per year in Africa. And of course, that comes with a loss of money in terms of treatment, loss of money in terms of control. So it comes with a huge socioeconomic burden. And under the same scenario, the additional severe cases derived from the increased transmission were estimated at around 365 per year, compared to what I showed you in the beginning that is happening currently. And therefore, this calls for us to develop strategies to manage this anti-malaria resistance and to manage the antimicrobial resistance as a global burden, because anti-malaria resistance is only a portion of the antimicrobial resistance that is a bigger problem globally. So this is my last slide. And on this slide, I'll talk about research priorities because I know a number of you are looking for research topics. A number of you are researchers. You want to do research. I'm not too sure how many of you are doing malaria research, but for those who are interested in malaria, this slide shows you some of the research priorities, including research on gametocyte carriage and transmissibility among parasites with mutations associated with resistance, identification and validation of new molecular markers for antimalarial drug resistance and their partner drug resistance, assessment of the degree of clinical and in vitro resistance conferred by the genetic changes in different parasite backgrounds, assessment of the fitness cost of these genetic changes mediating resistance, assessment of outcomes of patients with severe malaria that are infected with parasites that have these mutations. How does it compare to patients who are infected with parasites that do not have these mutations? Of course, measurement of drug concentrations and correlating these drug concentrations with parasitological outcomes. Then a big question is on the pharmacogenomics. In Uganda, we don't do a lot of pharmacogenomics research. It's coming up, more and more researchers are getting interested, and we are seeing more and more people doing it. But it's important for us to understand which SCT component resistance has emerged, how it's related to the other resistant parasites, and whether this is linked to partner drug or diagnostic resistance. Then assessment of the role of the immunity, individual host immunity, and of course, finally, the impact of this drug transmission, the impact of resistance on drug transmission in the population. I will stop there for now. I wish to acknowledge the Brown School here at the Washington University in St. Louis and the executive management and Dr. Fred Sewamala, Bethel, and your whole team present here, and the many friends that I have made here at the Washington University. Thank you very much for inviting me, and it's always a pleasure to come here.
I do have a question from the chat, if we want to start there.
You want to go ahead, Sarah?
Sure. So Andrea said, thank you for your very interesting talk. Sorry, the chat's moving. Let's see. And this person is, Angela's based in Uganda. She said, you mentioned that some countries in East Africa already have access to the malaria vaccine, but not Uganda. What determines which countries get access earlier than others?
Okay. Would you like me to answer one at a time, or would you like to read this a couple and I'll take them at this?
That's the only one that I have in the chat so far.
Good. Thank you. Okay. So our Ministry of Health is working very, very hard to be able to get this the malaria vaccine into the country. But just like you saw during the COVID time, the vaccines did not get to us as soon as we needed them. There was a lot of lobbying, a lot of meetings, a lot of politics, and a lot of financial, investment to be able to get these things in the country. So the question on what determines who gets the vaccine first, I think I cannot answer it now. But I'll say that the preparations are underway. And we think that we shall be able to get the vaccines in I think initially it was Q3 of this year, but it has been pushed forward. So hopefully in 2025, the vaccines will be coming to Uganda. But also to note that the vaccine is not for everybody living in malaria endemic countries, because the vaccines are not enough for everybody. They're going to be targeting those at highest risk. And in this case, it's going to be the children below 5 years of age living in areas of high transmission. So we are hopeful that 2025 will get the vaccine for those children. Thank you. Thank you for the question.
And Sarah, we were going to see if there's any in-person questions from our audience. Maybe I can turn the camera around.
Okay.
So, also very good presentation. It was very insightful. My question has to do considering the risk of resistance and the abuse of the antimalarials, and then the high incidence of the false negatives. And where do we draw the line as to what is good clinical practice because it's must? Because in my line of practice, actually came across a lot of false negatives. We ended up treating with the drug and we were better. So where do we draw the line?
Okay, that's a very good question. So for Uganda in particular, remember I talked about the deletions of HRP2 that we use for the rapid diagnostic tests. The research in Uganda has documented that these deletions are not that frequent. The prevalence is very low. It's less than 2% for Uganda, but these have been found elsewhere. And that's where you most likely get the false negative tests. But if a child is living in a malaria endemic area and they present with symptoms of malaria, we emphasize parasitological diagnosis before administration of antimalarial drugs. But we also emphasize that if the parasitological diagnosis is negative, but you, the clinician, investigate the patient and find that you don't find another reasonable cause of the symptoms that that patient has, and this patient lives in a malaria endemic areas, it's usually safer that you go ahead and treat them for malaria because of the sequestration that we have talked about. When the parasites sequester, many times you will not see them in circulation unless you're going to do serial smears. So it is safer that you go ahead and treat that child. Otherwise, the child will die within a few hours, dying of severe malaria. Okay.
Thank you. Well, against my hand, kind of stole the question. I have a little something about from practice. We have noticed that all the RBT that we get are sensitive to only the ossiparum. Most of the ones that we get now. Because of the time in my practice, we go on and I could predict what I'm going to see from the RBT. But after treatment, the patient gets fine. We are very much aware of the policies that are in place about treatment of malaria, making sure that you have parasitology to confirm your diagnosis. Right? And we go with our clinical experience and treat anyway. Patients come out fine. Are there changes being made in the development of these RETs and the special consideration the places that the RDTs are being sent to?
Changes in the RDTs? What kind of changes?
So, as you said, the ones that most affect us in the Sub-Saharan region are the falciparum and the Nulensi, right? So, the ones that we get mostly are for falciparum. It's been written on boxes.
Yes. So the reason, so there are different RDTs. There are P. falciparum specific RDTs. They will check for presence of falciparum. Why they're the commonest in the settings is because, for example, in Uganda, 99% of malaria cases are caused by falciparum. So it will be a waste of resources to distribute RDTs that are testing for Plasmodium knowlesi when 99% of the cases are caused by Plasmodium falciparum. That's the reason you see mostly RDTs for Plasmodium falciparum. However, we also have RDTs that target multiple species, and those come in fewer concentration, fewer percentages. So if you're living in areas where you have a dual infection, where you have multiplicity of infection of species, different species of the parasite, it's important that you stock those RDTs to be able to diagnose the other species. But also, if you suspect that your patient has malaria and you only have the Plasmodium falciparum RDT, you test and it is negative, and you have access to test for the other species, it's important that you test. At the beginning of this talk, I said Plasmodium ovale and Plasmodium vivax cause recurrent malaria because they develop what we call hypnozoites that hide in the liver, and those can cause clinical disease several years after the initial infection, several months, weeks, years after the initial infection. So if you only concentrate on falciparum and you're living in a region where mixed infection occurs, then you're going to get patients coming back, recurrent malaria infections due to those other parasites. So it's important that you test for them. I hope I have answered your question. Good, thank you. Any other question?
I want to jump in and thank everyone. We do need to end the webinar now, but of course, please feel free to continue the discussion and taking questions online. And I just want to remind everybody, whether you are online or virtual, that this presentation, a recording of it, will be shared on YouTube as well as our website, which that QR code will take you there. And if Dr. Pauline is amenable to it, I know that you had slides that you had prepared and were unfortunately not able to share the initial slides. If you would like to share the slides, we can also share those on our website. So thank you again, everybody who tuned in virtually, and we hope to see you at the next open classroom.
Thank you. Thank you very much. And it was a pleasure for me to give this talk.